professeur Moussafir. Je viens de demander une grosse salle d'applaudissements pour Riva AF qui n'a pas été c'est le plus large registre sur l'affiliation actuelle. On a écouté un registre, le registre de l'insuffisance cardiaque en Afrique. Il y a eu deux registres de l'insuffisance cardiaque, TSUCF 1 et puis TSUCF 2. TSUCF 2 n'est pas encore publié, mais qu'est-ce qu'on a appris de TSUCF 1? Et Dr Coquet, bientôt professeur Coquet, un de nos jeunes cadets qu'on a beaucoup encadré, mais qui est très brillant et qui va nous dire un peu ce que nous avons appris sur TSUCF. Il est enseignant de cardiologie à l'université de Boya. Clovis, you have the floor.
Thank you, dear Prof. It's an honor for me to present this work of the Teenage Heart Failures study, in which I participated as one of the site investigators for Cameroon, that is Boya. I have no conflict of interest. So heart failure is the most common pathway of almost all cardiovascular diseases, and it is estimated that about 4 million people worldwide are living with heart failure, and 80% of people, over 80% of people with heart failure live in areas of the world like Africa and low-income countries. And heart failure is a major public health problem, and most of our understanding or knowledge of heart failure is framed by data from Europe and America, and over 80% of people in the world live out of these areas of the world. In Africa, there has been significant improvement in the understanding of heart failure in the past 2 decades. The TESIS heart failure study, TESIS 1, was the first multi-center study to characterize the causes and outcome of heart failure in Africa. That was published about 2 decades ago. And since the publication of the TESIS 1, there have been significant improvements in the management of heart failure with new medications that have been shown to improve outcome. And since the collection of data for the TESIS 1, it is likely that the epidemiology of heart failure has changed because of increased exposure to risk factors like high blood pressure, adoption of Western lifestyle. So there was a significant gap in the epidemiology of heart failure that prompted the TESIS 2. So under the umbrella of the PASCA, the TESIS 2 was a prospective, multi-center, multi-country study aimed to provide updated and comprehensive data on acute heart failure in Africa. And specifically, they wanted to collect data on the incidence, epidemiology, clinical characteristics, and in-hospital mortality, 30 days and 6 months mortality, and also to obtain data on the diagnostic therapeutic processes applied to evaluate how complementary guidelines for the management of heart failure is currently followed, and identify parameters that could serve as prognostic markers. Regarding the methodology, data collection started in 2024. Like we said earlier, there was a prospective observational multi-country, multi-center study. Now, all PASCA member countries were invited to participate in the study, and over 5,000 colleagues were contacted from the PASCA database, and most of these colleagues were internists and cardiologists that took part in the PASCA heart failure course, because each year PASCA organizes a course called the PASCA heart failure course. And at the end, 75 sites showed interest to participate. Now, at each site, we had to collect information on the site regarding the population served, the number of patients they receive per week that present with dyspnea, and the tests available at the site to diagnose heart failure like ECG, echo, chest X-ray, and other advanced tests. So this participating site was required to provide knowledge of the patient volume and catchment area. Each site was required to be able to perform ECG, chest X-ray, echocardiography, be able to report the treatment, patient outcomes, inpatient outcomes and outpatient outcomes. So these are the participating countries. And in Cameroon, we have two sites, one in Douala and one in Buea, where I am based. So at the end, 50 participating sites across 17 PASCA member countries were involved and collected data from over 1,500 cases of active heart failure. At each participating site, once you collect data on the population that was served, the resources available in the hospital, the cardiology services available, and the instruments to diagnose heart failure, diagnostic tools and services, and then data on medications availability in the hospitals. Now when we look at advanced interventions that are available in the different participating sites, we see that no center offered heart transplantation, which is a treatment for advanced heart failure, and very few centers offered CRT and ICD implantation and diagnostic capability for coronary artery disease with PCI and coronary artery bypass grafting. We'll look at the gender distribution. There was no significant difference between men and women, and the median age of the participants was about 55 years. This is slightly higher than that of the Thesis 1, where the mean age was about 52 years. So the mean age has slightly increased, but is still low compared to that of high-income countries where heart failure occurs around the ages of 65 to 70 years. When we look at the risk factors, we see that hypertension still remains the main driver of heart failure in this part of the world, and about 36% of the patients had a previous history of heart failure. When we look at the distribution of the causes of heart failure, hypertension still remains the most common cause of heart failure, but what is striking is that there is an emergence of ischemic heart disease, which is the second most common cause of heart failure in this study, compared to the Thesis 1, where ischemic heart disease accounted for about 8% of heart failure etiologies. So, which means that our patients are still young and they develop ischemic heart disease at a younger age. On admission, about 20% had atrial fibrillation. Most patients presented with late stages of heart failure, class 3 and class 4, and the mean level ventilation fraction was 38%. Regarding hospital stay, the median length of hospital stay in the ICU was 3 days, and in the ward was about 6 days. For the medical treatment during admission, we can see that all the guideline-recommended medical therapies were available, but there was a lower proportion of the ARNIs. Almost 50% of the patients were on the glyphosate, which are relatively new drugs. For the outcome at discharge, the mortality rate was 9%, and TTD mortality was about 12%. So to conclude, the landscape of heart failure in Africa is changing from this data. So it is to identify that heart failure patients are about 2 decades younger than that in other parts of the world, and hypertensive heart disease and ischemic heart disease are the dominant causes of heart failure. There are major gaps in access to diagnostic modalities such as angiography and cardiac interventions. The high morbidity and early mortality rates underscore the urgent need to strengthen heart failure prevention, treatment, and infrastructure across the continent. Thank you.
Thank you very much, Clovis. So we have time for one question, one quick question, one short answer while the other presentation is being set. Et je vais laisser le professeur Moustafir modérer devant cette question avant qu'on ne passe à la présentation suivante. I hope it's not a language issue because Cameroon is quite. But moi, je voulais te demander, Clovis, I would like to know, so in Theseus HF2, I can see the distribution is largely better than Theseus HF1. But after all, 1,500 patients, why not more? And why not involving Francophone countries?
Thank you, Professor. Since most of those Francophone countries, they are not members of ASCAR, so it was really difficult to reach them. And also, the period of the data collection was not very long. For example, the Theseus 1, data was collected for a period of 2 years. So here it was quite short, just 8 weeks period of data collection.
Donc, pour rester dans le temps, je donne la parole au professeur Dodi Anastase pour nous parler